Welcome to Healing with Her, the podcast where women in medicine share bold and honest conversations from the front lines of healthcare. Step into the world of Black women medical professionals as they unpack the power of healing, the weight of care, and the beauty of showing up whole.
Welcome to Healing with Her, the podcast where women in medicine share bold, honest, and healing conversations from the front lines of medicine. I'm your host, Dr. Pamela Reed, and I'm thrilled you're here with us. Whether you're a healthcare professional, someone passionate about wellness, or someone who's looking to gain more knowledge about your own health and well-being, you'll find stories here that resonate, educate, and inspire. This podcast was born from a shared truth. Healing isn't just about medicine. It's about connection, listening, and leadership. And who better to lead those conversations than women physicians? I'd like to remind you that this information shared on Healing with Her is intended for educational and information purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other qualified healthcare provider with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of their institutions or employers. So I'd like to welcome you to our episode Fibroids 101, Symptoms, Solutions, and Support. I'd like you to be introduced to the panel of physicians here this evening. Dr. Sosa.
Hi, I'm Julie Sosa, and I am an OBGYN.
Dr. Nylander.
Hi, I'm Dr. Emmy Kool-Aid Nylander, and I too am an OBGYN.
And Dr. Rush.
Hi, my name is Dr. Teresa Rush, and yes, I am an OBGYN.
As it should be for this episode. So let's start with you, Dr. Sosa. Okay. What are fibroids for our audience?
So we brought a lovely little model for our viewers and listeners. So the uterus is a large muscle, believe it or not, just like your calves, just like your arms, the uterus is a muscle. And here, this red area shows us the muscle of the uterus. So these muscle cells just sometimes go rogue, and instead of forming normal uterine muscle cells, they decide to form these tumors that are benign called fibroids. So they overgrow, they don't follow the rules of the body, they decide that they're just going to grow more than the others, and they usually come to a consistency somewhat like a baseball, where they're a little bit firm but not golf ball hard. And in each person, they could grow at different rates, and they may remain small, the size of a pea. They could get larger, golf ball, grapefruit, basketball, and even bigger at times. So they are benign. They're not cancerous. However, they can cause a lot of trouble.
So, Dr. Nylander, how would someone know if they might have fibroids?
So they might feel a heaviness in their belly. They may feel pressure on their bladder. Sometimes it causes them to have constipation. If the large fibroid is pushing on their rectum, sometimes it causes pain, irregular bleeding. I've had patients who actually didn't know they had fibroids at all until they came in, and I actually did what's called a bimanual exam on them when I do their physical exam. And that's when I'm like, your uterus is a little bit larger than what I would expect it to be. And then we get a pelvic ultrasound, and it starts the ball rolling with, how large the fibroids are, where they are, and what they're doing to the patient.
All right, so you said pelvic ultrasound, and I know some of our listeners, viewers will say, what is a pelvic ultrasound? What does that entail?
So there's two ways you can do a pelvic ultrasound. You can do it's called transabdominal, where they just run this ultrasound on your belly. It's a transducer that's taking pictures of what your pelvic organs are look like inside. Or they can do transvaginal. Okay, so now there's a probe that's going into the vagina, and it's going to rest up against the cervix, and it's going to take pictures internally from inside the vagina. You get better pictures of like the ovaries for say. which can be then determined if there's cysts and things like that. But it can also give us better images of the fibroids depending on where they are.
So if I suspect that I have fibroids, what information should I be prepared to tell you, Dr. Rush, if I think I might have fibroids?
Well, let us know what your bleeding is like. Don't assume that just because your bleeding has been, 7 to 8 to 9 days, and that's the way you've always been, that's normal. Because honestly, it's not. I lived with fibroids, and I was one of those individuals that didn't know I had fibroids. I'd always had crampy periods, but they weren't heavy. And when they did become heavy, I just chalked it up to, that's just, my mom had heavy periods, my sister had heavy periods, so this is normal. So be specific. Come in with a menstrual chart if you can. Give us how many days do your periods last? How many pads, or nowadays they're using those little cups?
The menstrual cups.
Yes.
Yes.
How often do you have to go through that? Because I do have some individuals, women who really kind of feel that they change it like 3 times a day, and they're like going, oh, that's heavy, and I'm going, yeah, no. If you're going through, a pad or tampon or something every 1 to 2 hours, and you're soaking them, you're having accidents, that's abnormal. A lot of women who have fibroids will complain of back pain. And I know as we get older, we naturally think that, oh, I've got a little back pain, it's arthritis. But this is a little bit more than that, and it's probably going to be there all the time. In my case, I had a lot of urinary issues. I can remember flying into New York City, JFK, and I was like going, oh, I'm good. I don't have to go to the restroom. And they circled and circled, and by the time they landed, I had to run to the back of the plane to go to the bathroom, because your bladder, if you've got a fibroid that's anterior situated, it's going to be pressing on your bladder. So you're not going to be able to hold your bladder. And you're going to have probably some accidents with that. Intercourse can be a bit uncomfortable. So these are the things, even if they're not asked, you give them that information. You're having these issues. If you're feeling very fatigued, your periods might be so heavy that chronically your hemoglobin, which tells us how you're carrying your red blood cells, might be low, and you might be anemic. And if that's where your primary comes in, if they haven't done any blood work recently, have them check some blood work to make sure that you're not anemic.
All right. Anything to add, Dr. Sosa? Symptom-wise, or what you would want?
Oh, I could give one little anecdote.
Absolutely.
So we have pretty common symptoms that are experienced, and I love that we discuss the fact that it's not always related to just pelvic pain and bleeding. It could present as constipation or urinary frequency. I had a patient who, for the longest time, thought she had heartburn, and she was even on medication for heartburn for a while. And she's like, it's just not working. My doctor has to keep increasing the dosing. I just don't understand. And she was one of those patients who had not seen a GYN for many years. And so she hadn't had a pelvic exam. And when I examined her, you imagine that we're examining you lower down there, as folks like to say, and I could feel her uterus all the way up to her xiphoid, which is up to where her ribs are. So that big uterus was pressing on her stomach, making it, causing her to have that heartburny feeling. She was like, I always feel full. I can't really eat as much as I used to. So sometimes you have really nondescript things that, look like a completely different condition. And if you have something going on like that where, you're being treated, it's not getting better, you might want to start thinking about what else could it be. But also I think really shows the importance of just seeing all the physicians you're supposed to see. See your primary care doctor, see a gynecologist, because when we examine you, if that person was going to their GYN regularly, we would have already, on a simple exam, we would have known that this uterus was enlarged and this was the problem.
All right.
I would also add infertility issues.
Yes.
Okay, a lot of women are like, I can't get pregnant. I don't know why. And you know, one of the simple tests that we do, again, pelvic ultrasound or, you know, sonohystogram, something to see what's going on within the uterus could indicate that there's a fibroid that could be getting in the way.
So Dr. Nylander, that actually does bring me to my next question. What testing may be done if fibroids are suspected?
For me, the basic one is the pelvic ultrasound, which I already described, either transabdominal, transvaginal, or they can be done at the same time. Something called a CAT scan, a CT scan, okay, that basically looks at your body in slices, okay, and you go into like a tube, okay, and then they can image, thank you, image the body, and they can see fibroids through that image, or they can do an MRI, magnetic resonance imaging, which is it's a big magnet that allows them to take other imaging pictures and to see the soft tissue versus, you know, fluid versus hard tissue in the body, and can determine whether or not these fibroids are causing problems or where they are.
Is there a sequence to the testing that you do? So do you first have a pelvic ultrasound, and then do you go the next step and have a CT?
So in my office, we have the capability to do pelvic ultrasounds in our office. So that is going to be my first go-to, because it's right there, it's available. I can get that information very quickly. When I'm concerned about other issues with the fibroids, the size, or whether there's a malignancy associated with it, then, you know, I'll send them to an oncologist. But before I do, I'll, you know, have them get a CT scan, you know, because I'm concerned that there might be other issues going on inside that patient's body. So before I refer them to the oncologist or a GYN surgical specialist, I will get the CT scan as well.
So Dr. Sosa, we've spoken about imaging, which seems to be the gold standard for diagnosing. Is there any blood work that people have done in conjunction with that that's helpful?
Yeah, so when it comes to blood work, it sort of depends on what a patient is experiencing. So if there's someone who has heavy or prolonged periods or irregular bleeding, we'll do blood work. One, we want to rule out other causes other than just a fibroid. But like Dr. Rush said before, we want to ensure that they're not anemic. So getting that CBC is going to help us know where they're at, whether this blood loss is so significant that now they're anemic and we may need to replenish that. But also whether, you know, some folks may start off thinking, I don't like medication, I don't want to do anything. But if someone's anemic, and we have that discussion about what that strain on their body, on their organs means, then they may be more inclined and understand why it's necessary to be treated. And treatment, we're not there yet, but you may have some sort of hormonal or treatment or procedural treatment so that the bleeding stops and you're no longer anemic. Other than that, this is not, I will make the disclaimer that this is not standard of care, but we do know that folks with fibroids are more likely to be vitamin D deficient. And so I often would also check a vitamin D level to see whether or not that person is deficient and if we need to supplement that also. Again, it is not standard of care, but because of that link, that association between vitamin D deficiency and fibroids, in my practice, I've found it to be pretty helpful. And to move on to why it's important too, there have been several lab studies and studies done in mice showing that being on a vitamin D supplement daily can actually slow the growth of fibroids and slow the development of new ones. Now, it's not that you have a basketball-sized fibroid, you take a bunch of vitamin D and now it's the size of an orange. That is not the case. However, if you do have fibroids, I find it really helpful, especially for folks who may have a family history. So, everybody in the family has fibroids. We've now diagnosed yours. It may be the size of a golf ball. This may, and they're younger, so this may have potential. You're 25, you have another 25 years before menopause. So this has the potential to really grow in that time. So that you want to make sure, of course, that your vitamin D primarily comes from your diet, but putting them in that supplementation may decrease the potential of that large size fibroid to occur. And so it's important to know those levels. Again, see a primary care who often may do that testing regularly. And if not, when you're diagnosed, I tend to do it also.
All right. And so we've touched on treatment so far. Dr. Rush, what can be done for women who have fibroids?
Well, it depends on the symptoms and how severe they are and what your blood work looks like. If you're severely anemic, then we really do need to step up what we're going to recommend for you. If they have no symptoms, my adage is, if they're not bothering you, don't bother them. And that's if they're small and you just know that. I would say about 25% of Black American women probably have some fibroids, and that's between ages 18 to 30. 35 and above, that really bumps up to 60, and 60%. It's a lot. And some of us, as I said, it wasn't until I probably got into my maybe late 30s, early 40s that I actually had a problem with bleeding. So I take the adage that if it's not bothering you, we're going to monitor with ultrasound to make sure the growth isn't accelerated and that they look very typical. Okay. If they're giving you an issue, let's say your bleeding might be a little heavy but not excessive, we can talk about hormonal regulation, whether that's the birth control pill or patch or whatever works for that individual. I personally did the IUD. It helped me. I actually had it under ultrasound guidance because mine was so large. We had to figure out where to put it as it was going in. That's not for everyone, but don't be surprised if the doctor just says, you know what, let's do this under ultrasound guidance so that we know where that IUD is going. And in particular, a progesterone IUD, not a Paragard.
Not copper.
Not copper T. I'm going to say that right here. Not copper T. Your periods are going to be much heavier, and you're going to call me everything but a child of God. So you want a progesterone one. Something as simple as ibuprofen. I don't know if you guys, as their period is starting, we think about doing ibuprofen for cramping, but you actually can start that process where you're going around the clock with it, and it can help with the bleeding also. If you're not someone who wants to do anything hormonal or really are not a candidate because you've had clots or you've had a blood clot of some sort, you might be a little afraid because of your family history or something. Then something like TXA, not for a clot, but TXA is a medication that we do give our patients right when they have heavy bleeding. So they're not on something all the time.
Okay.
There are I'm going to let Dr. Sosa talk about the surgical ones, but I love to talk about my patients who are not, they're past their child rearing, and they just want a little relief. I will talk to them about a uterine artery embolization that's done by a radiologist. It's done on an outpatient basis, and it's not going to totally take away the fibroid. What it does is under I'm going to say this word,
Imaging,
fluoroscopy.
imaging guidance.
Yeah, imaging. They put, it's really cool, they put this catheter, usually some access the neck, some the arm, some less more the groin area, and they go directly to the vessels that are feeding that fibroid. And they put these little small pellets in that pretty much block the flow to it. So we can get up to about 40% decrease in the size over time. So this is like not going to be something that's overnight. It's going to take a few months to almost up to a year to get some shrinkage. And that shrinkage might help that woman who actually has problems with her bleeding, with her periods, or
And
bladder.
bulk.
Yeah, or bulk, yeah. You've got this huge uterus and you just need a little shrinkage. So talk to your physician. Don't, so many think that it's a surgical procedure all the time to address it, but we do have some non-surgical things.
And then, so Dr. Sosa, we're going to have you describe the surgical procedures that can be done.
What I really love now is that there are several options. I like to tell patients, today's fibroids are not your mama's fibroids, right? So back in the day, if you had fibroids that were problematic, everybody got a hysterectomy. That is not the case now. So there are many options in which you could keep your uterus. So Dr. Rush spoke about one procedure that's done by the radiologist. Surgically, there's another procedure that GYNs do called radiofrequency ablation. And since no one's sponsoring us yet, we're not going to say their names. But radiofrequency ablation is a procedure where your gynecologist does a laparoscopic surgery. So you'll have tiny incisions about the size of your finger, your index finger. You'll have 2 incisions. We use an ultrasound probe in the belly where we locate the fibroid. And then this little needle goes into each individual fibroid and releases some heat and burns the fibroid from the inside out, effectively making it inactive. So it no longer can cause bleeding. It no longer can cause pain, not immediately, again, over a few months. And then over time, it also decreases in size. So earlier on, we had talked about the fact that fibroids tend to feel like a baseball. Well, after this procedure, it tends to feel like a marshmallow. And so that bulk feeling that causes urinary frequency and constipation goes away with time. The heavy bleeding goes away with time. And your uterus is still there. You did not have a major surgery causing you to stay out of work for 4 to 6 weeks or more. You're back to work in 3 to 5 days. So that's wonderful. Outside of that, sometimes it's really necessary to remove the fibroids in order to actually improve one's health. Dr. Nylander had spoken about fertility. Sometimes fibroids can affect your fertility, and despite everything else that's done, you're still not successful in getting pregnant. And when we remove the fibroids, that actually helps. Again, there's a lot of research showing that even the presence of fibroids changes the way the uterine lining responds to fertilization in an egg on a cellular level. It could be a tiny little fibroid you could barely see, but the mere fact it's there, it releases these signals to the rest of the uterus, making it a little hostile to pregnancy. And that's not the case in every scenario, but it can occur. So when we've sort of ruled out everything else to affect fertility, if the only thing that remains is fibroids, then removal is necessary. And so that involves a procedure called a myomectomy, which is my favorite procedure to do. This procedure most of my surgeries are minimally invasive. So I use a robot, or we could do it laparoscopically. Again, those little keyhole incisions about the size of your index finger, where we go in and sort of individually cut the uterus and get each fibroid out. I describe it sort of like an orange. So the actual orange is the fibroid. The peel is the surface of the uterus. You want to cut the surface of that peel and then sort of get between the orange and the peel, pull the fibroid out, and then suture the peel back together. And that procedure, depending on how many and the size, can take, 3 to 4 hours sometimes in a big case. But again, it's useful in someone who really does not want their uterus gone for whatever reason they want. And I think that is your right to choose that. Or it helps with fertility. And of course, the fibroids are gone, so then your bleeding is less. The fibroids are gone, the bulk symptoms are gone, And I like to say I'm in the business of restoring normal anatomy. So that's what we do, right? We basically want to get the bad things out and keep what's supposed to be there. And same for endometriosis. And so myomectomy, sometimes we have to do an open procedure where it's like a traditional C-section scar, or if it's a really large, like that one we talked about before, up to the xiphoid, up to the ribs, you may need to do an up and down surgery to get something that large out of the belly. And then the final recourse, when either you're not a good candidate for a myomectomy for some reason, or you're thoroughly, completely done. Some women come and said, get this out. I am done with this thing. It has caused me too much trouble. I don't want to do one procedure that may or may not work. Just get it out. So then a hysterectomy is the option. And this is where we remove the entire uterus and cervix. And same thing, we could either do it minimally invasively with those small incisions, or a C-section type scar if it's a really large uterus where we can't get it out through the small incisions.
Okay. That was a lot of information. And so I want to let everyone know that we will have a link on our Instagram to give you further information, because I know that was a lot of information to digest at one time. Dr. Nylander, would you like to add anything?
I think it's really important when people are referred to GYN, OBGYNs for management of their fibroids, that you have that initial consultation and you talk over what is it that you want out of this, right? Because I have so many patients, like you said, I've had patients who've had fibroids all the way up their abdomen, and they look like they're 8 months pregnant. And they are so afraid of surgery. They don't want to get rid of their uterus, but it's important for them to know that if you're bleeding all the time or you're feeling weak, I've had so many patients. I had one patient, hemoglobin of 4, walking around. I don't know how she was managing. But, we sent her to the ER, to the hospital, and transfused her. But I kept looking at her. I'm like, is this how you really want to go through life, bleeding all the time, and then, being transfused? Because then she was starting to get iron transfusions. I'm like, when they finally do get the hysterectomy, they're like, I should have done this years ago.
We see that
all the time. So really think about your livelihood. What bothers you the most? I'm not here to tell everybody they need to have a hysterectomy. That's not what I'm talking about. I'm talking about your well-being.
Yes.
Okay.
Yes.
Which is very important.
Right. And your quality of life.
Quality
of
of
life
life
matters.
Quality of life.
Too
matters.
often I think we touched on this a lot, sort of subtly, that we push through symptoms and we work through because of our obligations to our families, to our jobs, and we normalize stuff that is not okay.
Yeah.
And what we see so often, that's why I really love what we do as OBGYNs, to be honest, is that many times the procedures we do really restore quality of life. And we see people on the other side of it who say, I should have had this done a long time ago, but you see how much better they do, not just health-wise, but the ability to function day to day, get back to your family, do do stuff that brings you joy instead of spending your time in ERs and in hospitals and in clinics because of poor health. So, it's one of the reasons why we do what we do, why we love what we do. Yeah,
Absolutely.
I love it. Anything else that we should touch on before we end this really informative episode? Yes, Dr.
I
Sosa.
think it's really important. I'm so glad that we are doing this. There is so much misinformation out there on social media in particular, where oftentimes I feel like folks are taking advantage of the vulnerability of women who experience fibroids and heavy bleeding and things like that. And because the medical world hasn't done right by us, right? Fibroids are understudied as compared to other things that go on in the reproductive world or in medicine in general. But because of that, and because of that lack of available information, then we get all these folks out there claiming all these different things that are going to cure fibroids and solve fibroids. People are spending a lot of money on herbs and teas and special drinks and whatnot to cure themselves or to shrink fibroids. And we have to be honest, those things do not exist. They do not work. Seeing your physician, and I'm not saying it just because this is my job, but really, we really want to do right by you. We really want to serve you well. And it really pains us, to be honest, to see you suffering all this time and spending your money on things where we know that, that 2-3 years you spent buying, subscribing to this one service that gave you this drinks, and then this fibroid has grown in that time. That's now, committing you to a more difficult surgery sometimes, where you may lose more blood in that surgery. You have longer stay. Whereas if we had done it earlier, then your recovery and everything could be even better. So please listen to the true experts, not those who tout themselves as experts online. Know people's credentials. Are they an MD? Are they a DO? Is this what they do on a day-to-day basis? And we're not trying to sell you anything. Right?
We want you to use your money to take that dream vacation.
Exactly. Go to Cannes.
Take me with you.
That you can actually do a flight somewhere comfortably.
If somebody's telling you and educating you and then say, oh, but buy my thing, that's when you should think twice about whether you should support it or not.
Great. Thank you so much.
Thank
so
you.
that brings us to the end of this episode of Healing with Her. We hope you found the information enlightening and empowering. Please find a link on our Instagram, Healing with Her Podcast, for more detailed evidence-based information on fibroids. Once again, to remind you, this information shared on Healing with Her is intended for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your physician or other healthcare professional with any questions you may have regarding your health. The views expressed by the hosts and guests are their own and do not necessarily reflect those of their institutions or employers. Thank you for joining us, and we hope that you continue to tune in for these amazing conversations.